past the hour. Maybe we can get started. I think there's probably still some people trickling in, but I have just some housekeeping that we can get kicked off with, and then we'll get started with our regular programming. Shannon, I can see the slides. I don't see them necessarily in presentation mode, but I may not be seeing the right thing here. Perfect. Okay, and you are recording, which is great. So welcome everyone. Thank you for joining us on this Saturday morning. Unfortunately, like the conversation that was just being had, we were hoping to be able to meet in person and do a little redo of our April boot camp, but unfortunately we're still kind of in the same boat as we were back in April, but really excited to still bring this group together again for some additional content and just to open up the doors to ask some additional questions, as well as we have started to expand our content a little bit and have some focus on remote patient monitoring since the acceleration of our telehealth implementation also, thanks to COVID, actually had us all actually using telehealth much earlier than we had originally planned for this group. So look forward to kind of digging into some remote patient monitoring topics today. And again, a great agenda, including a keynote from Dr. Kvedar, an introduction into some remote patient monitoring best practices, and then a couple of panel discussions that will focus on clinical application and quality and payment models for telehealth and remote patient monitoring. So a few housekeeping items before we get started. As mentioned, this will be recorded and we'll be able to share out with the group after. If you are interested in claiming CME for this boot camp, we ask that you please place your name in the chat box. We're going to record those names to have extra kind of verification when those CME requests are submitted to TMA. And if you have any questions along the way, please also place those in the chat box. We will be monitoring all of those questions for the speakers today or in general, and we'll get to as many as we can after each presentation. And finally, we encourage cameras. It's great to see everybody. And with that said, due to some tech limitations, during the panel discussions, we're actually going to ask that the participants turn off their cameras so that we can hopefully feature the panelists that are having the discussion. And we will remind everyone after when we get to that point in the program today. To quickly go over the CME information for today, there are no disclosures for today's presentation. This session is available for 2.5 AMA PRA Category 1 credits through the Texas Medical Association. And to quickly cover the objectives, after this program, we hope that you are able to describe ways to leverage remote patient monitoring solutions to care for patients with chronic disease virtually, determine best practices for remote patient monitoring, and develop a plan for implementation, workflow, and ongoing use, and develop and implement policies and procedures for remote patient monitoring use and reimbursement. So without further ado, let's get started with our programming for today. While Shannon is going to hand over the controls to Dr. Kvedar, I am going to do a quick introduction, if that is okay with everyone. I'm really excited to introduce Dr. Kvedar. We're grateful that he is attending. He was supposed to join us back in April in Austin. Again, unfortunately, didn't work out, but we are excited to have him here with us today. He's currently the president of the American Telemedicine Association, a professor of dermatology at Harvard Medical School, senior advisor for virtual care at Mass General Brigham, and editor of MPJ Digital Medicine. At Mass General Brigham, which is a part of Partners Healthcare, Dr. Kvedar has focused on driving innovation, creating the market, and gaining acceptance for connected health for nearly 3 decades. He's now applying his expertise, insights, and influence to advance adoption of telehealth and virtual care technologies at the national level. He also continues to guide the transformation of healthcare delivery as a respected thought leader, author, and convener. Dr. Kvedar is president of the ATA and served as program chair of the ATA 2020 annual conference. As editor-in-chief of Nature Partner Journal Digital Medicine, he is working to establish the evidence base needed to guide innovation and implementation of digital health. He also co-chairs the AMA's Digital Medicine Payment Advisory Group, which works to ensure widespread coverage of telehealth and remote patient monitoring, and successfully established several new provider codes for telehealth reimbursement through the CPT process. He's a member of the AAMC's Telehealth Committee, creating tools that will enable medical schools and residency programs to integrate telehealth into the training of future practitioners. So welcome, Dr. Kvedar. Thank you so much for being with us today, and I am going to hand it over to you.
Thanks so much, Stacy, and it's a delight to be with everyone this morning. As we were talking off mic, as it were, beforehand, we all were lamenting that we couldn't get together in person. I think we all do have that longing for unity. Having said that, these types of gatherings are incredibly important to keep us all connected in the meantime. So I'm pleased to be able to be part of it. I would also say that my relationship with AMA has been incredibly productive, and it's our 4th year now on the Digital Medicine Payment Advisory Group. And that's just been really a lot of fun, and it's been a delight to work with all the folks at AMA around that topic and my fellow panel members. That said, I'm with you today wearing my ATA hat, so I would be remiss if I didn't say a word about ATA to start. I think many of you know the American Telemedicine Association. If you're not involved, you should be. Now, coming from me, who's a soft sell individual, I've never been a hard sell individual, but I really mean that at this time in history, with telehealth reaching its apogee, there's just no better time to have an organization that's kind of has its oars in the water for all of us, finding the rising tide floats all boats initiatives that we can all get behind to move the industry forward. And I, with all humility, think we're doing a very good job of that right now, particularly on the policy front. So you can see on the slide some of our members. You can see a little bit about what we're doing to work on. I don't want to dwell on it, but just to say ATA is an important part of moving this whole vision forward. And we do have a number of collaborations with AMA ongoing. So I'm also delighted that our sort of topic for today is remote patient monitoring. I won't say too much about that, at least in detail, because there's going to be so much more coverage following me. But what I do want to do is set up the need for why we have to go in that direction. And you'll see in some of my remarks in a few minutes that it would be tempting for many of us in the industry to sit back now and just say, wow, we've achieved so much in the last 4 months in telehealth. Maybe it's time for us to all take a break, smoke a cigar, whatever you do, maybe have a glass of wine or scotch. I would suggest that that's not the right way to look at this. And it's because of what's illustrated on this particular slide. And this is a curve that shows the demand for services and the supply of clinicians. And you can see that it's out of whack since 2020, and it's only getting worse as we get older. As we get older as a society, we have more chronic conditions, we need more care, etc. Now, there's one thing about this graph, though, that could easily be fixed, or I shouldn't say easily, but could be fixed, and that is that it presupposes that the interactions between clinicians and patients are one-to-one. I used to say one-to-one in an office because this used to be my slide to tee up my telehealth conversation. Now we have one-to-one in your living room as well. And again, we should celebrate that. I don't mean to not, but it's not adding to our efficiency. And remote patient monitoring has enormous potential to do that, which is why I always go back to the real goal here, pandemic aside, is this notion of one-to-many care. How can we use things like software, chatbots, AI, other healthcare professionals than doctors, nurses, to get our patient care in a way that so many other service industries have already done, whether it's flagging a ride by Uber or having food delivered to your door. You have a digital front end, and then there's human being services somewhere in there. I dare say that in healthcare, again, while we've managed to get that healthcare connection into the living room, that should really just be the beginning. And we need to do more and more. And again, remote patient monitoring is a perfect example of how to achieve one aspect of this one-to-many notion. So I'm really delighted to be able to put that charge to all of us today, as there's so many leaders in the audience who can help make this happen. Now, I want to say a word, and I will be brief because it seems now like quaint old news. These are slides that were shared just before the pandemic really took off. But the reason I do this is because people might be under the impression that telehealth became literally an overnight sensation. And I think those of you who study innovation and participate in innovation know that that just never happens. All of the things that are listed on this particular slide are things that were happening before the pandemic took hold. Consumers were getting comfortable with technology, particularly with video, whether it be FaceTime or Skype. We, as we've already said, and we've created a number of reimbursement opportunities through the CPT process. If you like to say, well, I don't really want to go fee for service, I want to go value, telehealth is a beautiful fit in a value-based payment arrangement because it does add some efficiencies. And of course, all of the people entering the workforce, both the consumers of service and the providers, are all digital natives now who they don't understand why we don't do everything by text message. So I think these foundational elements were really in place. And as the next two slides illustrate, adoption was happening. So the next one is about consumer adoption. This is from Rock Health. This is 2019 published data. And you don't need to look at the details. Please don't distract yourself. But just generally speaking, as the timelines go on, the numbers go up. And you could say on the left-hand side, just for focus, the live video telemedicine one, around 33%, 34, then 32. That's a 2018 and 2019. So about a third of people responding to this consumer survey had some clinical care delivered by telehealth. That's non-trivial. That, again, is sort of table stakes to go where we went. And this is from our colleagues at AMA. I had to promote their survey data, 2016 and 2019. And doctors, we used to tell the story how doctors were lagging behind, how really most doctors viewed this as a curiosity or maybe something where they would say, well, you know, I've got a full waiting room and a 6-month wait. Why would I want to change my care delivery model? And you can see that in 2016, 14%, again on the far left, pretty limited adoption, but that had doubled in 2019. So again, if you extrapolate the curve, we're headed in the right direction. So there was something going on in the marketplace before that. And then of course, in the middle of March, we all were told to stay at home, global public health emergency, and yet we as clinicians had to take care of our patients. So overnight, these things happened. And the government helped us by relaxing regulations in the categories illustrated here. I'll talk some more about a number of those. But reimbursement, which again, we've hinted at, all of a sudden, payers kind of paid for everything. If you can do it via telehealth, payers were paying for it, and largely still are. We're still under public health emergency. The technology part is by saying that there would not be enforcement of HIPAA. You could use any platform. That's still in effect now. That probably will be dialed back. And then of course, right now, 49 out of 50 states have eased licensing restrictions for telehealth. So you have this mix of an environment all of a sudden that's pro, and you have this notion, at least we did till mid-June, where the only thing we could do was deliver virtual. So virtual care volumes, of course, went way up. And telehealth is now a household word. Now, I don't want to, again, I have limited time and I don't want to make this seem like a triviality, and I don't want to dwell on it too long. But if you have any training in public relations and you have any experience, you know this is a non-trivial matter, that you can go to any organizational meeting now, virtual or otherwise, cocktail party or Zoom cocktail party. And if you bring up the term telehealth, people will know what it means. Patients have had visits, doctors have done it. And it's huge for moving our industry forward that people have that familiarity now. In fact, as I said earlier, the one thing that we can all say we have achieved at this point is we brought the doctor's office into the home successfully. And we should be proud of that because a lot of things could have gone wrong and not many really did. We've done some pretty good research on that and not found any real issues with untoward events or problems or what have you. So I applaud my clinical colleagues for jumping in with both feet when they had to. And of course, our patients for being patient with us while we figured out video, et cetera, et cetera, et cetera, did some things by phone. But it all went relatively smoothly, and we should be proud of that. And these are just some of the numbers. And the question is this a harbinger of where we're headed? Well, right now, as you probably all know, we're actually a little bit back into the scenario of something less than this because we're in a hybrid model now. But there was a huge jump, and everybody, I like this slide because it's not just healthcare providers, it's also some of the vendors. Everyone saw huge increases in their volume in this time frame. So the trends to watch going forward, well, I've talked about the regulatory equilibrium. All three of those things need to be tended to and watched and how they turn out. And I don't have a crystal ball on any of them, but I think they're all going to be better than we were before the pandemic. I really do believe that. And of course, there are some, again, details, and maybe some of those will come up in the Q&A or in the discussions later. I would say that one of the things that's going to happen now that everyone's had this experience with virtual visits, and I will touch on all three of these in a little bit more detail momentarily, is that there will be this series of things that will be implemented in the home for the patient, which will make the indications for virtual visits grow. And those are the things listed here: digital biomarkers, home devices, and home lab testing. Again, I'll come back to each one of those. We're going to see more asynchronous activity. Why? Well, because it's efficient, because we can get a lot done that way. And remember, in terms of your one-to-many, that's your first step in the journey of from one to one-to-many, because you can do it like an email. Think about how much more efficient handling email is than having everything by audio call or video call. And you'll get a sense of how asynchronous can be really powerful. And then, of course, remote patient monitoring, which is the subject of the discussions this morning. What are the business implications of where we are right now? Well, it's really fascinating, but every healthcare provider organization that I've talked to is looking at their brick and mortar, these fixed costs that we've had for centuries, that we've assumed for centuries are necessary for us to deliver our care. All of a sudden, people like me can be in this particular room, which is my kid's bedroom, delivering services. I do Tuesday afternoon telehealth now from this room. I'm not adding any overhead to the Mass General Hospital when I do that. And everyone is sorting out what that means for them. How do they actually maximize their brick and mortar? And how do they provide, allow providers to provide services in the home? How does that change the cost of practice expense? All those things are up in the air right now, and people are really thinking through them. Payers are frightened, as you might imagine, and we, I think, owe it to them to come to the table and talk through some of these issues. They're really worried that, and this is an example from my own practice, a patient sent me images of a lesion on the hand. It looked to me like it needed a biopsy. We had her in the next day. I only billed the E&M for the telehealth part and the biopsy for the biopsy part. But you could see that someone, without thinking too hard, wouldn't think that through and would bill E&M twice, because we're sort of trained to do that sort of thing. That's what payers are worried about, that sort of thing. We have to figure out how we can work with them to make sure that that's minimized as we bring to this new model of care to the fore that provides more access and convenience for our patients. What's the right mix? And really, this is an important thing that's going on right now throughout the industry. Specialty societies are tackling this, individual practitioners. Now that we're in a hybrid environment, you say, what should I be doing by telehealth? And this comes up over and over and over again. Now, this chart isn't exactly that, and I almost didn't show it because I don't want to distract people on reading the chart. What I'd like, because it is a reflection, so if you bear with me and don't pay attention to the title and just look at the graphic, you'll see that ophthalmology is way to the left and on the top, which is why I chose the picture that I did as well. My wife's an ophthalmologist. She's probably done 3 or 4 telehealth visits total in the last 6 months. Because why? People need to come in and be in the machines to get their visits done. They need to be in the office. Contrast that with mental health on the bottom. Now, by some estimates, 80–90% of mental health can be done by telehealth quite well. Some people would say even better than in the office. So that's interesting. And then everything in between. But every clinician and every specialty has to go through this. And the rules for me are, can you do what you need to do, either diagnostically or therapeutically, without touching the patient? And if you can, it's fair game for telehealth. If you need that physical contact, then the patient has to come in. Now, I know that's oversimplified and there's a lot of nuance there, but it's a starting point. And I have to say, a lot of clinicians are going through that exercise. We all need to go through it. I'm hoping that we can get some traction at the specialty societies to do this in a very kind of formula way. So yes, we've successfully brought the doctor's office into the home, but that should really only be the beginning of the next wave. And I implore you all to not take it as a victory, but as a next step in the journey, because we need to get to that one-to-many care model that I talked about. We're not going to be able to tackle the demand for healthcare services in much longer if we can't do that. We can't just keep adding providers. We can't train them fast enough. They add too much cost, et cetera, et cetera, et cetera. We have to think about how to use our physician labor in a different way. So it's really our opportunity now that telehealth's the household world. People are, oh my gosh, I can get cared virtually. Doctors saying, you know, I didn't think this was any good, but I actually did a lot during the pandemic. Maybe I could do this. Everyone's thinking about it. Everyone's minds are open. Let's try to reimagine how we deliver care. Now, my sort of analogy for the dilemma we're in and where we are right now is aluminum. When Alcoa invented aluminum, they had this new material, very light, very strong. They could bend it, ply it, put it into things. And I have pictures, I didn't include one here, of a coat rack that you could swear was made of wood that was made of aluminum, because for the familiarity of the consumer at that time, people took aluminum and painted it to look like wood. I think that's kind of where we are with telehealth. We've taken our office visit and moved it into the living room. We need to reimagine completely how we deliver care. And we get to beyond the stage where we're thinking that somehow bringing the office visit into the living room is the end of the journey. It's only the beginning. So as I said, looking at our brick and mortar differently, this is a rendering of a hospital building that we had planned to build at the Massachusetts General Hospital. It's on hold now. It's on hold because we just lost $1.5 billion, but it's also on hold because we're rethinking how we use our brick and mortar. Everyone's going through this. Really, really important for us to figure that out. As I said, one to many, and I should add that the companies on the slides are not companies that I have any relationship with, save one, which I will mention. They're just examples of people that are doing work in this particular space. But one to many is a concept that pervades everything that we've been talking about. And again, what I mean by that is the idea that maybe there's a chatbot on the front end that's just software that does symptom checking or triaging for you. We've seen a lot of that with COVID symptom checking, and it seems to be useful in that way. Maybe there are many other indications. You know, I called Apple support the other day about a computer issue, and for the first 30 seconds I was on with a computer and then quickly got triaged to a human being. But that's one to many, and they did it really well, and I felt like I was well cared for. We can do the same. So we can integrate these kinds of software front ends and AI channels and not have our patients feel out in the cold. We mustn't do that. We have to do it the right way. As I said earlier, the idea of home testing. So one of the virtual urgent care use cases that we talk about a lot is sore throat. Now, take COVID out for a minute. Sometimes sore throat means you might have strep. The dilemma, does the doctor prescribe an antibiotic without a strep test? She shouldn't do that. Imagine if you had something that was like a pregnancy test that you could do in your home for strep, or in this case, something for, I mean, there's just any number of the picture here is from a company called Boston Microfluidics that does a little droplets of blood, not unlike Theranos, but actually doing it. And they're doing things like COVID tests now for the home cholesterol, et cetera, et cetera. So when you think of that armamentarium being added, all of a sudden your value of your virtual visit goes way, way up. These are an interesting set of companies, digital biomarker companies. I am an advisor to ResApp Health on the top left. ResApp Health is an Australian company. Their software will, by the sound of your cough, diagnose your respiratory illness. And so you can imagine, I've got a cough, I get on my video call and the doctor says, cough for me. She doesn't need to listen to your lungs at that point. That's interesting. And Beyond Verbal has done this with other indications. Sond, mainly in the mental health space, based on the tone of your voice, can tell if you're depressed or not. And there's lots of these popping up. And over the next few years, they're just going to continually integrate with the Teledocs and the Amwells of the world to give you a more rich experience as a clinician when you go to make a diagnosis. I mentioned asynchronous, I mentioned chatbots, symptom checkers. These are all important, or some of the companies on this slide are what I call specialty telehealth, like Nurex, Women's Health Only, HIMSS, Row, you've heard of, Babylon. They're all doing these interesting things where they either combine, Babylon is combining a lot of chatbot work on the front end. Now, truthfully, none of them have got it 100% right yet. So, but I give them a lot of credit for trying and for being disruptive in the field, and we need to pay attention to their work. We need to try to help them be successful because we need to achieve this one-to-many model. So what I want to conclude with is a vision that we should, I believe, all strive for. And I alluded to some of this throughout. But I, as a consumer, have a healthcare issue that I need solved. I go to my mobile device first. That's my first link to the healthcare system. Not that way right now. In my practice, sadly, people call, they have to leave a message and someone calls them back. That's our version of digital right now. We need to do so much better than that. So you get on your phone, you have an issue, you go to the app, you integrate your issue in, and then the app will guide you. Maybe it triages you to go to the emergency room if you're really sick. Probably it triages you to virtual care if you can do that. Maybe it triages you to urgent care. If you need to go to a local urgent care, maybe it says there are 5 nearby and the wait time is 10 minutes in this one. That's a good one for you to go to, et cetera. And then when you get there, if you go to a place like the Mass General, the Brigham and Women's, there's wayfinding to guide you to where you need to go. The experience is completely integrated. And of course, on the back end, your bill's automatically paid and you get to understand what, when, and where, just like Uber. This is where we need to go. And I hope you all can embrace that and go there with me. I'm excited about it. It's, again, virtual. Getting your visit into the living room was a great first step. We've got everyone's attention now. We need to harness it and move forward. So very pleased to be able to deliver those remarks. I think we'll have some time for some rich Q&A here. And those are my contact info if you wish to read about me or get in touch. And I'll hand it back over to the AMA team for questions. Thank you.
Thank you so much, Dr. Kvedar. That was awesome and great. I will take any questions now in the chat box. And or Shannon, I don't know if we want to have participants unmute themselves. That's an option as well if you want to ask a question.
Sure, yeah, just unmute yourself and you can certainly ask.
Sounds like you just answered everyone's questions.
I was going to say, this is
did such a good job that there's no questions.
All right, that's brilliant.
This is Tom Cornwell. You are so on top of all this. Where do you see continued payments from CMS in terms of after the emergency is over with telehealth?
Well, thank you for asking. So this is a great way for me to put in a plug for all of you because you're all influential, to contact your elected representatives on this issue. I'll say a couple things about that. The most fundamental thing that we need to fix is the originating site rule. So what does that mean? Medicare, before the public health emergency, was restricted by law to only pay for telehealth visits if the patient was in a health profession shortage area, as defined by CMS. And that is a very narrow window of mostly rural folks. With the public health emergency, that's gone away, but it's a statute, it's not a regulation. And Congress needs to change that if they lift the public health emergency, we'll go directly back to that. And it's incredibly limiting. So any influence you have on, and I keep saying the next time, if they, God willing, if they get to a stimulus bill, we should get this tucked in because it's incredibly important. There are a few other things like the fact that federally qualified health centers and rural health centers can't now utilize telehealth. I mean, they can now, but they need to be better. That the HHS does not have the authority to allow providers to come on board and bill. So there are a number of things like that, but the main thing is this originating site rule. We're going to have to wrangle with private payers, of course. That's a foxhole by foxhole fight. But as I said earlier, if we sit down with them and try to work through with them, remember, all of you know this, there are plenty of examples where telehealth will lower cost if we implement it correctly. So I think we have a lot we can do there. But at the federal level, it's all really about that originating site rule. I'm so glad you asked.
I have, sorry. Russell Libby, I'm just going to ask you a quick question, because what is apparent to me is that the consumer is way ahead of us in terms of their expectations and their appreciation for this kind of care. And when you deliver that care to people in their home or whatever place they choose to receive it, the reception is incredible.
It is.
How do we get the consumer to be our biggest voice in advocating for continuing support to do this?
Yeah, I agree with you. And so I talk about now, sadly, if you do the wrong thing. So again, go back to that virtual urgent care scenario I talked about, and you've teed that all up. You've got this mom at home at 10 o'clock at night with a baby bouncing on her knee who's got a sore throat, and you say you've got to go to urgent care because you've got to get a strep test. We can't be doing that, right? So it's this magic of convenience, quality, and access. When those three things come together, patients know it and they love it, and you're quite right. And I think it would be well worth any of us who have advocacy arms to try to do as much as we can with the patient advocacy organizations to get the word out as well. I totally agree with that.
If I might, my perception of all revision of healthcare centers on something that we are woefully weak at, which is measuring quality of care. Especially in chronic care. I'm a solo practice neurologist. When I do telehealth, the time I spend with the patient is less. I'm very efficient, but I don't get paid. Even at parity, I'm going to get paid less, even if my quality is equal or above what I was giving before. So it starts with measuring quality, which is an ongoing problem. And then it is, what is parity? If you're advocating for parity and it turns out you're paid less because you're more efficient.
Well, so I totally agree with the emphasis on quality for sure. And there's a lot of efforts going on in that world. I think the parity payment thing, so I'll just give you, this is my view. This is not an ATA view. My view is that I believe this, I don't have proof of it yet. So it's a hunch and we're working on some data that practice expense when you scale telehealth will be less than in the office, that you should be paid the same for your time and your complexity. And as you know from your E&M world, it isn't always about time. If your complexity of the care you deliver over that link is the same, but it's more efficient, you still should be able to get paid, I think, based on complexity. So we'll see how it all works out. But that's my thought on that. It's more about the E&M service that you deliver, I think.
We have a few questions from the chat in here. Dr. Milan, you had a question about explaining the benefits to reluctant patients. So interested to see if Dr. Kvedar hinted a little bit around that related to Dr. Libby's question. Yes, no. Okay, well, we can dig a little bit deeper into that one after.
Do you want me to restate the question? Or did you want Dr. Kvedar to answer it?
I was more asking if you got your answer a little bit based off of his
oh, I see.
Dr. Libby's question about engaging patients, and I heard a lot of conversation about patient advocacy groups and things like that. So
got it. Okay.
But go ahead and ask additionally too.
Yeah, I was just wondering, Joe, this is Judy Mellon.
Yeah.
Great presentation. Hi. I was just wondering if for the very small number of reluctant, recalcitrant patients who are objecting strenuously in comparison to the huge number who are welcoming this with open arms, have you found particularly effective talking points to move
Well,
this?
this might, so I'll have a bunch of caveats, but my first answer is have them come in the office then. You know, again, now this means that they're safe and that there's no risk to them to come, which of course is never zero risk, but we, as you I'm sure do, we clean the rooms, we can't people in the waiting room, so we try very hard. But that's the first thing as well. It's safer for you to stay at home. The second thing is we can do this now, whatever now is, like in 10 minutes instead of you spending 50 on the road and 50 in the waiting room and whatnot. But again, if people really think that there's some people, and let's face it, this technology is not being in a room with someone. It's not. So that's why we still have a need for the office and the hospital bed. And if people really feel like they want to come in, I just tell them to come in.
Thanks.
This is Dan McDyer from Florida, Dr. Kvedar. Thanks a lot for an awesome presentation. I just thought I'd add something in there. I did a survey of about 150 to 200 of my patients that were actually in the office and asked them about their opinions on telehealth and what they'd be willing to pay for it and things of that nature. And 57% said they'd be willing to pay for it out of pocket and do telehealth, which was pretty impressive. I'm an OBGYN.
Mm-hmm.
There are a lot of aspects of care that can deliver through this. A question I had is, you know, in my mind, we've just had the largest case study of the effect of telehealth on the delivery of healthcare and the cost reductions that could be implemented here. Has anybody, or is there any way to look at this? I know I'm a member of a huge group of OBGYNs in Florida. We have about 400, and Aetna has just agreed to pay at parity for our telehealth care. I don't think that's specific for us. I think that's for the state of Florida. So that's a positive indicator. Maybe they've looked at this. Have you seen any information about data coming out about the diminished cost of care with the implementation of telehealth here recently?
Well, I'll say two things on that. One is that there are a lot of people that are working on various data sources, mostly claims data, and we could probably spend another hour talking about whether that's useful or not. But yes, mostly claims data. I would say the following though, and it's really a word of caution. Remember, I'm an evangelist. I fully believe that this can be of lower cost. It's not a good experiment. All of a sudden, we just took everyone and said, you got to be virtual for the next 2 months. It's impossible. There's no control group. There's no real way to sort that out. Maybe now that we're in a hybrid mode, we could do for the next 6 months, we could look at it and maybe that might be useful. But looking at the time between, I think March and June is fraught for that particular question. That's just my opinion.
Joe, this is Adrian. Does the ATA or do you have an opinion on patient-controlled or patient-centered health records as part of telemedicine push?
Well, I do. I honestly don't know if ATA does, but I'm, of course, as you know, because we've talked about it forever, a big believer that the record should reside with the patient. We should have interoperability. Those are all easy things to say and, of course, very challenging to achieve.
Okay, we do have some questions still in the chat box, but in the interest of time, I think maybe I can gather those and I can share those with you, Dr. Kvedar, and maybe we can come up with a way to document some responses and send out to the group after, if that works for everyone. And awesome.
Thanks for inviting me, everyone, and I hope
you
productive
so
day.
much.
Thank
you so much, Dr. Kvader. This was great. Shannon, I know you're going to introduce our next presentation and pull up some slides.
Okay. Well, I did have this in presentation mode. Let me try one more time. There we go. So we'd like to have a poll question. We're going to go into discussing remote patient monitoring, and would love to know where you are with it, if you've started using it or not. So if you would just take a moment to answer this simple yes and no question. I see the answers coming in quickly. Impressive to see that so many are using remote patient monitoring. Give it just a couple of more seconds.
Shannon, there was a question about defining remote patient monitoring, I guess in relation to the question. So remote patient monitoring would be any type of equipment that provides any biometrics that your patient uses at their home, and either digitally or just through reporting or whatever gets that information to you, the physician.
Thank you, Yvonne. And I'm going to go ahead and end polling and share the results with you. So a slight majority are using remote patient monitoring. So this is good to see. And in the next discussion, we will have Yvonne Moon-Koon and Isan Biari. I'm going to take down the polling. They will discuss do an introduction to remote patient monitoring, and I'm very pleased to have them. Yvonne Moon-Koon, RN, BSN, MA, she is our quality practice management consultant for the Texas Medical Association and is just very knowledgeable in this area, as well as Bisam Biari, MHA. She is a senior practice solution specialist with Massachusetts Medical Society. Both of these ladies are very well versed. I know that you will learn something from them. So at this time, I will pass it over to both of you, and thank you for presenting today.
Thank you, Shannon. So it was very interesting that Dr. Kvader said that telehealth is appropriate if you don't need to touch the patient. And the wonderful thing about remote patient monitoring is that it makes that possible. Go ahead and advance to the next slide. So there's some benefits to remote patient monitoring that you'll see here on the slide. The improvement in chronic care management, there's some folks in Boston Partners Healthcare that started doing some remote patient monitoring with hypertension, congestive heart failure, and diabetes. And what they saw was a 50% reduction in readmissions for CHF patients, a 1.5% drop in hemoglobin A1Cs for their diabetic patients, and then significant drops in systolic and diastolic blood pressures after 6 months as a result of utilizing patient monitoring equipment in conjunction with the rest of their healthcare. So there's also an issue of increased compliance with medication regimen. The technology just continues to increase exponentially. There are special watches, alarms, pill boxes, things like that, that just, somebody who's just forgetful about taking their medication can utilize. There are others that will keep pills locked and open at the particular time that they're supposed to take their medication, things of that nature. And then others will even transmit, they have containers that will transmit a signal to a home health company that's involved in the patient's care that they have, accessed the box to take their medication, or they have not accessed the box to take their medication. So lots of different pieces of technology that can be utilized to help patients with their medication compliance. And then of course, the support for appropriate patient prioritization. So let's say you've got a couple of CHF patients that are recently transitioned to home from being in the hospital. You're really trying to reduce that 30-day readmission rate. You're monitoring a few of them, and you notice that somebody's had a significant weight gain, or they're having an issue with their blood pressure, something of this nature, and maybe your other patient is doing just fine, or maybe has a little bit of something. You can prioritize who needs to be contacted first, who needs a home health visit, who needs to come into the office, who needs to go to the ER, things like that. And again, you're intervening at that point in an exacerbation in real time, so that you can intervene and hopefully avoid that hospital admission or the ER visit, things of that nature. Go ahead and advance, please. And some of the challenges, patient preference and acceptability. Now, the one thing that's really great about remote patient monitoring is that you really increase your patient engagement. They're at home. They have to put the blood pressure cuff on their arm. They have to, access an app to, see their blood sugar level if they're using like a Dexcom or something of that nature. So you do get a lot of patient engagement. However, you also have to make sure that the patient that you're referring for this kind of service is, going to be open to accepting that type of monitoring. What kind of devices are they willing to use? Somebody might be willing to put on a blood pressure cuff, but doesn't want to necessarily wear a wearable watch all day long, something of that nature. And then there's an issue with attrition. When people are first home from a hospitalization or something of that nature, they're still in that convalescent stage, and are really concerned about, continuing to get well. Later on, as they get to feeling better, and their numbers are all starting to stabilize, they might decide, oh, I'm not going to take my blood pressure this morning. I'm not going to step on the scale today. So you do have some issues with attrition that way. So just some things to think about as you're planning on how to keep your patients engaged in the remote patient monitoring program. There are off-the-shelf devices that patients can purchase themselves, or access apps on their own, so they don't have to go out and buy special equipment. Pretty much most people in the world these days are carrying around a smartphone or have a computer in their hand. Social media provides an outlet for some information sharing, and even gaming systems, believe it or not, because of all of the internet and Wi-Fi capability, they can even use those to access internet and Wi-Fi. Another challenge is the management of data. There's a flow of information from the patient to the provider, and there's a lot of ways that information can get there. Whether it's patient reported through a patient portal, or whether it's information that flows directly from the device they're using through Wi-Fi and gets right into their patient electronic medical record. It just depends on what technology you're using. But the flow of information can be challenging, and making sure that you're monitoring that, and that you set limits on when things are going to be monitored, things of that nature. Then of course, the challenge of training, which I don't know if it's really as much of a challenge as a task that has to be undertaken when you're starting to use any new technology or implement a new program. But health professionals, as well as patients, need to be trained on not only how does the remote patient monitoring work, how does that information flow from patient to provider, but how can you help with troubleshooting? You need to be prepared for those patient phone calls, patient emails, whatever, when they have a concern about their equipment. So there's a lot of training that has to take place. And then probably our largest challenge, and this is a telehealth in general challenge, is broadband connectivity. The rural and underserved population areas tend not to have access as easily as some of our more urban or suburban areas. And so that's an ongoing challenge. Go ahead and go to the next slide, please. All righty. So the technology is very exciting. You can have technology that continually assesses a patient's health status by monitoring biometrics. Just yesterday, actually, Shannon had forwarded an email to me about a wearable that Amazon is now coming out that will calculate your body fat percentage and even has a way for, you just wear it on your wrist like, any of the watches. It doesn't have a screen, but it can actually hear your voice, the way you're speaking to somebody, and give you some feedback on how that must have sounded to the other person, kind of like a little bit of a psychosocial assistance. It's amazing what the technology can do. But continual access to that information is not always necessary. Again, you have to take it on a patient-by-patient basis. There's several components to the technology. You have the input device, which is the piece of equipment itself. If it's going to Wi-Fi transmit or transmit automatically, there's a local storage device, which could be the device itself, or it could be an app that it goes to. And then there's telecommunications involved, where you get that information from where it's stored to the provider. If it's connected to an electronic medical record system as well, then there might be a central data repository in that program. And then, of course, the diagnostic application software, which is something that's still developing with, the AI and all of those kinds of things that are on the horizon and that are being currently talked about. Okay, so you got these benefits, you got these challenges. You want to take care of these patients at home. You can't touch them during a telehealth visit, but you need a blood pressure. You can't touch them during a telehealth visit, but you need a weight, things like that. All of those things can happen and augment your telehealth. So you want to really look at what the readiness is, both for your practice and for your patients. Sorry, 1 second. My notes, there we go. So, for your practice, it's about understanding the technology and being comfortable with it, testing it out, having any type of demos, things of that nature. And then you have to have availability of staff. Obviously, if you're doing continual monitoring, that requires a lot more manpower than does, a daily blood pressure reading that might be sent into your office. So there is an availability of staff that you want to make sure that you're thinking about when you're talking about implementing a program. And the supporting technology, both in your office and what's available out there, what's available for your patient, things of that nature. And then you want to also look at your ability to develop a call system. Do you need to use an answering service? How are you going to have, what's going to be your policy and procedure for dealing with patient values that are out of range, that need attention, things of that nature. So all of those things need to be thought of in the readiness preparation for implementing a remote patient monitoring program. And then, of course, with your patients, do they have the cognitive skills, and are they comfortable and familiar enough with technology to use these things? Do they have physical limitations? Are they able to get up and stand on a scale? Are they able to put on a blood pressure cuff, for instance? And then the home environment, is it conducive to having this equipment and things of that nature? Are there other family members or other caregivers that are there to assist with utilization of the equipment and sharing of the information from the results, things of that nature? So equipment selection, software selection is a huge, wide open field right now, just because there's so much technology. You saw Dr. Kvedar talking about the company out of Australia, and in my research, there are just companies all over the world that are starting to develop these types of systems. So some things to consider in acquisition of these programs is how much is it going to cost? Is it going to cost the practice money? Is it going to cost the patient money? Will the patient be purchasing the equipment and then own it? Will they lease it? Will the practice purchase a program and then then provide that to the patient. Certainly, if you're in a value-based care model, that might make some sense, because then the practice can purchase that stuff and then use it for their patients and in those capitated type contracts. You want to think about your vendor, whether they have sufficient tech support, not only for your staff, but for your patients. Are they going to store that information in the cloud? How is it going to be managed? Is the product compliant with HIPAA and with other types of regulations? Is it portable? Does it have a battery? Does it have a battery that needs to be changed? Does it have a battery that needs to be charged? Things of that nature. And then as far as actual implementation is concerned, you want to really be focusing on that EHR integration. Probably, especially if you're starting a new program, a new telemedicine, new remote patient monitoring program, I would highly recommend that you focus on integration at the very beginning. When you start pulling different pieces of software, different programs, different pieces of equipment, you really do run into a bigger problem with interoperability. So, when you're looking at implementing, you're looking at your selection of equipment and software, really try to go for things that are already fully integrated. HIE connectivity continues to be an ongoing issue. So again, if you can kind of deal with that at the very beginning, you won't have to change as many things or add as many things later on. Some of these things are like just plug and play. You just turn them on and they automatically connect with whatever apps and software programs, things of that nature. Some will need some peripheral devices or the Wi-Fi with the routers and modems, things of that nature. So just some other things to think about when you're looking at deciding which pieces of equipment and software programs you want to deal with. And then last but not least is how easy is it to use? Not just for your patients, but for you and your staff as well. How's the call routing going to work? How is the staff training and the patient education going to work? And do you have a vendor that's going to deliver equipment? And if they are they going to be part of providing that education to the patient? Or does the patient have to come into the office with the equipment? And actually, that's not a bad idea every now and then. Something like with a blood pressure cuff, just to make sure that that the cuff is working properly and that the readings are similar to what you might see in the office. So anyways, just all of those things, you want to think about how easy it is for not only your patient, but for your staff and yourself as well. Let's see. Okay.
Right, can advance the slide for me, please.
You needed to go forward one more, Bisan.
Yeah, of course. Thank you, Yvonne. Good morning, everyone. I just want to make sure that you guys can hear me clearly. We're good? Okay.
Yes, you sound good.
Sounds good. So moving along, after you developed your conceptual model, the next step would be to design your care team to support your workflow and maximize their roles by ensuring they're working at the top of their license. Your team will serve on the front line, collecting and reviewing the clinical data, setting protocols, engaging patients, providing clinical technical training, learning new workflow procedures, and operating the RPM solutions. Identify staff leaders who can help develop, position, and socialize training materials. And as you see on the slide, next one, Shannon, if you don't mind, next slide. As you see on the slide, here are some clinical roles and responsibilities. For example, your medical assistant will help in device tracking, maintenance, inventory planning, ongoing troubleshooting related to the device use. Your practice manager can create and run reports on metrics for success, interface between care team and the administrative needs. Your nurse manager has a critical role here too. As you can see, the nurse manager or your care manager will help with patient education, test the device, the techniques with the patients, ongoing care management and coordination, assist and triage patient readings, symptoms, and concerns, monitors daily readings from patients, take actions depending on variance in measurement values. Next slide. So partnering with patients, defining your patient-based population will help you determine the extent of your program. Consider who will be your potential patients. Is that going to be your geriatric patients? Are you going to take your pediatric patients? Are you going to take all your patients with chronic conditions? And then which conditions are you going to manage? Cardiovascular, pulmonary, diabetes, kidney disease, and now COVID patients. And then of course, time assigned for management. Will you set a time limit for those patients who you're managing, or will you manage them throughout their life? Then as you prioritize, finalize eligibility criteria for the RPM program, and then apply these criteria to identify eligible patients through your EHR. EHR has capabilities now to do some population health database query, or through your recommendation or your staff identification. And for your set of eligible patients, identify those who are likely to succeed. Do you want to partner with patients who are more active in their care that you already have, or one who have or on a current care plan? Plan to introduce eligible patients to the program at their next appointment or through direct or virtual communication. Identify how will they enroll in this program, and then finalize training protocols and materials for the patients to participate. Also ensure you're prepared to initiate workflow, the dispute, and active these devices. And also your vendor will provide you with a wide variety of patient training materials to support different learning styles. And it's always safe to develop a clear what-if scenario to inform how the patient should respond to their readings. Let's advance one more. And that's continue what I was mentioning. And let's do one more. Yeah, let's stay here for a second. So why partnering with patients is very important. Research shows that giving patients access to their clinical information and have them invest in their own care empower them to increase engagement to improve their health outcomes. Patient engagement is essential to maximize the impact of your RPM program because many RPM program solutions require daily active participations from your patients. So our goal is to build strong personal connection between the RPM team and the patient and give that sense of dedicated clinical support to them when they need it. And then when you're assigning your staff and doing your roles, you want to assess who is the best person to meet or call the patient and explain the program. Also consider the language that is used, warm and personal, especially when you're dealing with an older population. Like for example, when you say, would you like to try this new technology? The word technology may scare them, although now most of patients are using FaceTime and using all kinds of things during COVID, but the word technology might scare them for a little bit versus saying, how about using this device that will help you while you're at home and keep you out of the hospital? Just an example. Using techniques like motivational interviewing and counseling to understand their needs and generate excitement around how this RPM solution will help them reach their goals, identify what will motivate them to continue participating in their care. Of course, we want to build this relationship as well with the patient caretakers to keep the patients accountable and help using the device and transmitting data. Also, having a good relationship with the vendor can support patient engagement to provide additional customer service. So preparing the patient to deal with issues that might encounter them, like the difference between a technical and a clinical concern. Help them set expectations about what their data will look like and what would the data points will be normal versus the need for a medical intervention. Comprehensive preparedness is vital to ensuring that your patients are confident in the technology, participate and generate accurate data, know how to translate or actually send you this data and how important this data will contribute to their care, and feel empowered to troubleshoot issues that may encounter. And let's do one more. So I know there was a question that just came about the codes. I just want to put a little disclaimer that the reimbursement information that we're sharing is information only, and as listed as in the CMS website. Please consult with your billing team before starting any of these programs to determine eligibility and medical necessity and coverage and assess your ROI. And also these codes are for Medicare Part B. So in January 2019, 3 new codes for remote patient monitoring came into effect. We in the industry, we use the word RPM. Actually, CMS define it as remote monitoring of physiological parameter, because CMS is specifically in the definition to emphasize the collection of data associated with vital signs. There are specific guidelines for these codes. For example, patient consent and how often do you do the reading. I won't go into much details because we're running short on time, but they are available for you within the resources in the material that we sent over. One of the CPT codes, I'll say 99453, and that's designed for the initial setup. So this is a one-time code to set up the device and do patient education. And the education can be delivered in person or via phone. The average reimbursement for this code is about $21. Of course, check with your locality. CPT code 99454, this can be billed monthly to cover device supply and daily readings or program alerts transmission. The average reimbursement for this code is $69 per patient per month. CPT code 99457, that's 20 minutes or more of clinical staff, physician, other qualified health professionals in a calendar month, requiring interactive communication with the patient caregiver during the month. So this code is to cover the review of the data, and the average reimbursement is $54 per patient per month. I will say before the public health emergency, this code had to be delivered under direct supervision, but there was a waiver that was put in place, and I'll mention it in just a second. And then in 2020, CPT code 99458, which is adding another 20 minutes of clinical staff time and physician qualified healthcare professionals in a calendar month. One thing I will say about RPM, since we are still waiting to learn more about the future of telehealth, payment and coverage, RPM is actually not going anywhere. So it will be a great revenue generator for you. And one more. And let's go one more. And just a very quick update about the waivers that were put in place. And I'll run through them quickly. And if we didn't have time, there is a link at the end of the slide that you can go and look for those waivers on the CMS FAQs. And I highly recommend that you keep checking all the FAQs that CMS is coming up with, because they're adding new waivers. And one thing also I will add, the new proposed rules had some information about remote patient monitoring, and a lot of qualifications and clarifications are actually coming in. So we will be looking into that once the rule passed. So many of these waivers starting March 1st and for the duration of the public health emergencies, RPM services. So for example, RPM services can now be furnished to both new and established patients. Normally, you needed an initial office visit to start the program, but with so this is similar to CCM for care management services that can be required via a telehealth visit, but regardless, CMS is not requiring patient to be established in order to receive RPM services. CPT code guidance for CPT code 99454 cannot be reported when monitoring occurs for fewer than 16 days of a 30-day cycle. Now for COVID patients, monitoring for fewer days than 16 or 30 days, but no less than 2 days, can be reported as long as all the other billing requirement is met, and the receiving patients must have a confirmed or suspected case. Another flexibility, like we talked about, under the general supervision, when physicians, other health professionals are faced with potential risk for themselves or patients, the direct supervision requirement may be met virtually through audio, video, real-time communications. Patient consent has to happen to receive these services, but it can be obtained by auxiliary personnel under the general supervision. And I know one small thing that came in the chat is the descriptor for what devices can you use. So, and this is from CMS, the CPT descriptor for the RPM codes require the device used to capture the patient's psychological data must be a medical device as defined by the FDA. This device is used to capture patient's physiological data, must meet the FDA definition of being a medical device. And if you want to learn more about these devices and the waivers associated with qualification with these devices, we added some resources at the end for you, at the end of the slides for you to look at. There are more informations about the waivers, but we are running short on time. So thank you very much. And I'll turn it back to Casey, Stacey, or Shannon.
Yeah, thanks, Bisan. Thank you, Bisan and Yvonne, so much for that presentation. It was fantastic. Folks, if you have any questions, feel free to type it in the chat, and Bisan and Yvonne can maybe answer some of those. And afterwards, again, we are happy to answer all of the questions and send that out post. So to segue from that great presentation, we do have a couple of panels that we've prepared here for you. Our first panel focuses on best practices for the application of telehealth and remote patient monitoring from a clinical perspective, as well as translating traditional in-person aspects of care into the virtual environment. So good segue from that last conversation. It's my pleasure to introduce Dr. Kate Curley, who will be moderating today's panel discussion using telehealth and RPM solutions in practice. Dr. Curley is the Director of Chronic Disease Prevention and Improving Health Outcomes Group at the AMA, and specifically leads efforts to advance chronic disease prevention through utilization of digital health solutions and improving medical education. Prior to the AMA, Dr. Curley was a practicing physician and health service researcher at North Shore University Health System, as well as a clinical assistant professor in the Department of Family Medicine at the University of Chicago. So thank you, Dr. Curley, for joining us. I'll turn it over to you to introduce the rest of the panel. And just as a reminder, we ask that all participants turn off video during this segment, just so we can see the panel. And Dr. Curley?
Thank you. Thanks so much, Bernadette. I'm so happy to be with you all this morning on this beautiful Saturday. Thanks for the intro. I'm going to just take 1 or 2 minutes to quickly tell you about some of the work at the AMA, and then I'm going to ask my panelists to each introduce themselves. So at AMA, as Bernadette said, I'm Director of Chronic Disease Prevention. Chronic disease prevention is actually one of our major strategic initiatives at the AMA. We have a team that actually works directly with healthcare organizations to implement quality improvement programs, specifically related to improving blood pressure control around the country, as well as preventing type 2 diabetes. And so our team is working with healthcare organizations every day and dealing with a lot of these practical questions that I think we're going to talk about here in this panel. We also do a lot of work kind of on the healthcare ecosystem front, really sort of advocating for reimbursement for things like self-measured blood pressure, which is a great example of remote patient monitoring, as well as incorporation of self-measured blood pressure into quality measures, making sure codes are available. Actually, we have a major initiative around educating physicians about validated blood pressure devices, because many of the devices out on the market are not validated for clinical accuracy. So we both work with healthcare organizations directly to improve their quality of care. And then we have a lot of this larger healthcare ecosystem work to make it easier for doctors and care teams to deliver high quality care. So really pleased to be with you all this morning. And why don't I ask each of our panelists to tell us who you are, where you are, and a little bit about your telehealth and remote patient monitoring experience. And Dr. Garber, I see you popping up on my screen right away, so why don't you first?
Sure, thanks. I'm Larry Garber. I'm the medical director for informatics at Reliant Medical Group. I'm a practicing internist. At this point, I'm only doing video visits. I do them, like Dr. Kavader, 1 afternoon a week. I do them from my home. We're a 500 provider multi-specialty group practice located throughout central Massachusetts. I turned on our video visits in 2 days when all hell broke loose in March. And all of our providers have been using it. And there has been obviously some transition back to in-office, in-person visits, but we continue to do a high volume of video visits. I'll let the others talk.
Thanks so much, Dr. Garber. Dr. Bott, why don't you go ahead and introduce yourself?
You are mute.
I think you're on mute. Story of Zoom.
There we go. All right, story of Zoom. Thank you for having me. So I'm the director of telecardiology and outpatient cardiology at the Mass General Hospital. And we actually started telemedicine back in 2013. So we've been working on it for a long time, and our adoption was about 8 clinicians pre-COVID. We're up to 134 clinicians now within the first 48 hours after we were able to turn on our EMR integrated system. So a sea change for us. We're now working in the direction of really trying to move towards blended care and not replace what we're doing for in-person care, but really figure out what are the strengths where we can actually get better care done, more continuous care. And I really am in the blood pressure camp along with you in terms of really preventing future cardiovascular disease. For us, RPM is key. We were already doing it a lot in devices and heart failure and electrophysiology. However, where we're really trying to improve upon this is the use, and I know in the chat there was some comment about whether it's watches, activity monitors, single lead EKGs, blood pressure cuffs, weight and continuous glucose monitoring in the community. How do we put together the right system of RPM for the right populations of patients so that we can really do a better job in outpatient care, which should be episodic care, which shouldn't be episodic care, but really should be continuous care. So excited for our discussion today.
Great, thank you. And Dr. Mishra. Mishra, my new colleague, go ahead and introduce yourself.
Thank you, Kate, and thank you for the AMA colleagues to put this in a wonderful conference here. So I'm a very new member of AMA. I joined about 4 weeks ago as a director of digital health. And I have honor working with Kate, so I'm really excited about that. I also serve, I'm associate professor of medicine at VCU Health System, internist, and also lead virtual health system or a telehealth for VCU Health. And we have a very rich history here at VCU, Virginia being one of the pioneers in a lot of different things, but also we started our telemedicine journey about 20 years ago. But the implementation has been very, very small to begin with. It was just for Department of Correction. And through the years, last 3 or 4 years, we have really expanded and created a systems of care together. And of course, most of us will kind of look into and kind of think about what was pre-COVID and post-COVID. So of course, there's a huge change. We do have lots of programs, and I'm looking forward to talking about that, including remote patient monitoring for chronic care diseases, also transition care management, also cardiology. So lots and lots of programs to talk about. Thank you, Kate.
Wonderful, great. So let's dive in, and we're really going to try to focus on practical considerations for implementing telehealth and RPM in clinical care. And I know the next panel is going to go into a lot more detail related to payment. I think we'll largely try to stay away from that issue here. But let's start with some basics. I'd love to hear from you all sort of what are common conditions or clinical scenarios where telehealth and RPM work best? Maybe where do they not work so well? Where do we start really? And let's go in reverse order. Dr. Mishra, why don't you go first?
Oh, yeah, Kate, thank you. You're so kind. So it's very interesting you asking that question. I think we are all right now thinking about new ways of applying telehealth in a lot of different directions. And I think we all are recognizing for sure low acute conditions, being sore throat, being conjunctivitis, rashes, exacerbation of chronic diseases, COPD, asthma, very easily can be seen and managed. Thinking about chronic care, and you just talked about, you kind of lead that area at AMA as well, a lot of chronic care. I think majority of chronic care can be taken care by using telehealth, and especially when you kind of blend it with remote patient monitoring, you see wonderful outcomes. Counseling. Think about, the number of counseling, and I want to surely kind of point out some of the things we are looking into data at VCU, and what we saw that actually our counseling and psychiatry department is doing 120% of their volume as compared to pre-COVID. So that's fantastic to kind of think about also. And I also want to kind of comment on one of the recent publication by McKinsey, which said it's $250 billion opportunity, more than 20% of the visits which we see outpatient can be seen virtually. So I think lots and lots of opportunity there, but I think it's going to continue to evolve as we develop our technologies and comfort with our practitioners.
Yeah, that's great, thank you. And Dr. Bhatt, I think you have a maybe slightly more subspecialized view, but anything to add there to build on?
Yeah, no, absolutely. So I think one of the key things is that we have noticed there is still some provider and patient adoption issue. And you'd be surprised with that, but we're not. And so we're finding that sometimes using the ability to just look at imaging studies that have been done over televisit and educate the patient about what they had happen has been an excellent introduction for patients and for providers. And from there, then being able to give them vital signs has been the next step for us, where they say, but hey, what am I missing when I actually do my visit? And for a cardiologist, it really feels as if that's the main issue. And so I think those two have been a great introduction. Are you guys getting an echo, or is it only me? No echo on you. Okay, I'm sorry, I'm hearing an echo, so if I'm slowing down, that's why. So I think that's been a great introduction in terms of getting people up to par. Once we do that, I think the blood pressure cuffs have been phenomenal at home. Our ability to get people to kind of guideline-directed therapies, to get people to the right blood pressure so much faster than we used to, has really made the case for a lot of patients.
Yeah, and that's music to my ears. We, have offered guidance to healthcare systems about self-measured blood pressure for years now. And COVID has really sort of flipped that switch in terms of the level of interest in really implementing that well. And now our team can't keep up with supporting healthcare organizations and doing that, but we're so happy that that's here now for all of us.
As you say that, if I could just add one other thing, which is, you said our healthcare systems can't keep up. So as the director of outpatient cardiology, one of my goals is, what is the workflow? Because if you don't give clinicians a workflow for how to deal with the data coming in, you cannot get them to do it. And you worry about quality and safety. So we've really reorganized who are the people responsible for seeing the data come in. How are we going to use algorithms to highlight the data that may put patients at risk? And when do we need to say, let's take that patient because of this remote patient monitoring and then bring them back in? And so I think that's been an incredibly important part. If you don't have workflows for remote patient monitoring or telemedicine in general, you can't ask providers to just figure out how to do something completely differently than they did before.
Absolutely, great point. And Dr. Garber, anything to add on there?
Yeah, I agree with everything my colleagues have said. I think the one thing I'd say is, instead of saying what kind of visits can you do by telehealth, it's actually what kind can't you do. It really should be a rule out. And another thing to think about is, maybe someone with abdominal pain, you might think, oh, well, obviously you have to be dragging them in. But the purpose of this can also be for triage. In other words, it doesn't have to be the full visit. It may be a better way of triaging the patient to deciding whether they truly need to come in for a physical hands-on visit. And then also in pediatrics, we've actually had, mothers palpate the belly of the kid for the pediatrician so that they can get a feel for how tender the belly is. I've been shocked at the kinds of visits that we've been able to do. I had a 91-year-old patient that I was managing her congestive heart failure over the video visits. We've got physical therapists doing video physical therapy sessions. So it's really been remarkable what you can do with this technology.
Absolutely. And I know a lot of folks on the call right now, you know, have been implementing telehealth rapidly with everyone else. And everyone is starting to get a sense for kind of what can you do, what can't you do so well. Could you all talk with us a little bit about what do you think are really key best practices? Dr. Bott, I heard you talk about, for example, that you need to make sure you get some good workflows in place, obviously, for sure. What else? What else is a great workflow? And I'll actually, Dr. Bott, I'll kick it back to you first this time.
Sure, absolutely. So I think key best practices is just going back to the beginning, actually teaching providers how to interact over the video. You would think that it comes naturally to everybody now with Zoom, but it doesn't necessarily. So we actually have a checklist for them, like make sure you don't have a lot of backlight, make sure in your place where, you know, you're on the Wi-Fi as well as on your network. Try not to use the phone, but rather use your laptop or iPad if you can. And so we do some of those basics because if providers get frustrated with the technology, then they won't continue with you. And so just the very basics, not making it seem like people don't know what they're doing has been really helpful. I think the second part of just best practice along those lines is reminding people that if they are at all uncomfortable with what they are seeing over a video visit, there is nowhere in our practice that we say you cannot bring them in following a video visit for an in-person visit. And we really kind of re-emphasize that because a lot of people think, well, I did that, now will I, whatever it may be, get paid, will the patient actually come? Well, and so we really set that expectation. Then during the actual visit, there's a few things. So one is we do ask our patients, we have medical assistants as part of our workflow who are calling patients in advance. They are playing the role of tech support, kind of like, you know, the Apple tech support or Google tech support. So they play the role of making sure the patients can get on and get on successfully before they've even gotten to their physician's visit or nurse's visit. At the same time, they ask the patients, do you have the following things? Activity monitors, blood pressure, weight monitors, things that we know that we've been giving out through the Mass General Brigham kind of telemedicine services. And if so, could they make sure that they've uploaded that data? That's obviously for a more capable population of people who are comfortable with telemedicine already and RPM in terms of the patients. And then lastly, in terms of best practices, it's not always the patient who will do the majority of the communicating with you. There's often a daughter for an older person who needs to be there. There are parents with the teen. And so making sure that all the invested parties, if not in the same place, people don't realize that you can call someone in from somewhere else. And so we make sure that that's part of the conversation that our medical assistant has as well in the prep work, which is if there's somebody else you want to be present, we can make them be present from wherever they are in the country, just let us know.
Yeah, that's really helpful. So not just the visit itself, but really preparing for the visit well, it sounds like there are some key best practices. Dr. Garber, anything to add on the best practices front?
Yeah, I think there are a few tips. You know, as Dr. Bott said, some of this training goes for the patients as well as for the providers and staff. You know, we tell our providers that, you know, as I said, I'm seeing patients from home, but you should dress professionally. You know, I've got my ID badge, and so it looks like you're in the office. We also want to make sure that patients are finding a quiet, private room. Certainly, you know, those have been issues where I've, you know, had a patient, you know, in the car and you know, and that doesn't, while he was driving, wasn't exactly a good way to ask him to show me a rash. I do disagree with Dr. Bott about the phone. We actually encourage our providers to use the phone so that the computer can be used for our electronic health record. So I've got the full screen of my EHR open on the computer, and then the phone is dedicated to the audio and video. But if you do that, it's really important where you position the phone. You want to have it, you know, very close to the screen, ideally, you know, close to the top center, so that it's not looking at your throat. So there are some tricks about where you position that. Also, if you are using the phone, you want to have it plugged in so that you don't have power issues. You know, you're doing a day of schedules, you know, your phone will burn out that battery. We also encourage patients and providers to shut off other apps that might be on their phone or on their computer to make sure that these are running as fast as possible and minimizing the bandwidth. As far as the bandwidth issues, we find that sometimes if it's starting to break up, you want to stop moving a lot and stop using your hands because that actually ends up using more bandwidth. And occasionally I have to shut off my own video feed so that the patient's video feed gets priority on the bandwidth. For derm rashes, we are have patients take a photo and send those to us and view those on the big screen, because those are higher resolution than what you're going to get from the video. When we book appointments, we ask the patients to give us their phone number, because you need to have a backup plan. Just like Dr. Bott, we do have the medical assistant calling in and getting them into the visit, and we use that phone number. But also, if during the visit something goes south, you want to be able to contact them. So it's always good to have that phone number. And we, as a corollary to that, we've also found it useful to have a backup video solution. So we actually have 2 video solutions. One is our primary, but if that one's not working, which as everyone's seen over the last few months, Zoom is sometimes out, but the different technology vendors are down. It's nice to have a backup plan that you can use.
Absolutely. Dr. Mishra, anything to add? What are you telling the organization or best practices now?
I really like what Dr. Butt and Dr. Garber said. I think they covered most of the etiquettes, talking about technology best practices, talking about the best practices in the workflow. I think that's all very, very important to kind of consider. I also, many times, training providers, I say, this is a force multiplier. The telehealth is, any technology is. If you're a good provider, with a good bedside manner, you need to have a better website manner. So I think that is really a critical part of the conversation, as how do you present yourself? The history taking. I think we all know at a medical student level, 80% of our diagnosis is made with a history. So, and I think many times an in-person visit, we do have, shortcuts. It looks like we can do this. But here, I think having some more depth conversation around history to really kind of find if this patient, first of all, is the right setting at the right place. I think Dr. Budd talked about, contingency planning in terms of, hey, if this patient is not doing well, what are the next steps? And we have to define those things. If the patient is feeling like he's short of breath, who calls the EMS, right? How do we really support the patient through that whole encounter and taking that ownership with you? And sometimes you cannot, and that's one of the things which we kind of look into. Also, physical examination, I think Dr. Garber, you talked about it, assisted physical examination by the patient. And the best practices, I think, Kate, we are developing best practices. Most of the physicians, providers are actually inventing it. And the best thing we are looking into right now, and we launched some time ago, post-acute hospital medicine discharge care. So each patient gets post-discharge after 3 days, virtual visit, making sure that everything, all loose ends are tied. And we didn't have any best practices there. We came up with some PRIDE best practices. And what we found that it decreased, and the satisfaction of the patient, it increased so much more. It decreased more than 20% of the readmissions or the issues which was happening. So again, best practices, I don't know, there's so much more. And Dr. Garbus talked about, this was very funny, and I think this is very accurate, which one we cannot do. And I think we have good practices all around as to established workflows, established clinical use cases. But I think we are inventing it, and I think we need to have a way to collect it and then really refine it and do a PDSA around it.
Yeah, all great points. And I know we're starting to get a couple questions from the audience, which I want to take in a moment, but I want to pose one other question I have to you all, which is, I've been hearing a lot from friends, colleagues about frustration now with telehealth. It started up so rapidly. The physician experience is not always what we would hope for. So what have you been learning? Do you have any tips for how to improve the physician experience? Any suggestions for anyone? And anyone want to go first? Who wants to go first this time? Dr. Garber, go ahead.
Sure, I'll grab that. I think the one lesson that we learned, I mean, we didn't have a choice. With 2020 hindsight, it would have been great if we did this a year ago. We were just playing around with a non-integrated pilot. So when we went live, we had a standalone separate solution. Now we do have an integrated solution with our EHR, and it's so much easier for myself and my staff to use. So if you have any way you can do it integrated with your EHR, that usability helps us and the patient. Also, if the patient doesn't have to upload an app to be able to use it, if it uses this web RTC, which automatically from their browser starts the session, those are the kinds of usability things that makes it more doable.
Dr. Bott, anything you want to add there?
Yeah, I'll jump in. We had an epidemic before, right? Like we had physician burnout, and it still is an epidemic, but it was kind of the last epidemic before COVID. And it's not really gotten better as a result of asking people to change what they do. And so there's a few things. The first is laying on of hands is one of the reasons a lot of these people went into medicine. And you're telling them that 80% of the time that is not necessary. And even though we won't have a full conversation about it, that's really hurtful to a lot of people. And it's very hard to reimagine themselves in another way. And so we have that conversation right up front, actually, with people. It's not that, you know, it is your clinical intuition. It is a new part of your practice. It is a blended practice, not a replacement of in-person. And I think that's got a long way to engender people's trust in the fact that we're not trying to change who you are or what you do. We're just trying to bring all of ourselves into this new age, and we think it will be better. Feedback from physicians, honest listening feedback about what is not working, and then quickly trying to address those things. That's how the MAs now have a completely new workflow, is that the physicians were like, if someone's not going to figure out how to get them on Zoom, I can't do it for every 80-year-old grandmother anymore. It's not part of what I am meant to be here to do, and I still have to do my Epic notes and everything else. And so it was an additional strain on them. So I think really listening to people's feedback and trying to even solve things that may seem very small but really important has been helpful. And then lastly, just in terms of getting people on board, we've recognized that you need clinical champions throughout. And so we have very large, all of us have very large groups that we're responsible for. Mine's probably the smallest out of this, panel, but still I find that I need people who can be at the elbow help, who are reliable and trusted face. And so in a way, you need to have physicians or nurses or admins who people know and say, hey, if you have any trouble today in your clinic, call Laura, and Laura's going to help you. And that, I think, was the biggest thing we could have done in terms of making it better. We tried other things. We tried things like, I found it better, since I've been doing this since 2013, to not have virtual visits interspersed in the middle of a clinic. So for a long time, I taught have a clinic separate with virtual and do your in-person clinic separate, right? Don't combine them. And a lot of people who've done this a long time will agree. However, in the setting of COVID, if you need an hour to turn over a room, et cetera, and you're sitting there and not generating RVUs, actually integration makes sense. And so I think on our part, as people who are implementing it, which is maybe a majority of the audience here who's on the call, being flexible about our own thoughts and our ways is probably equally important.
Actually, can I jump in on that for a second? Because we're doing the same thing, interdigitating, well, not me because I'm working from home, but everybody else is interdigitating office and virtual. And we found there's an interesting problem in that normally for the in-person visits, the patient would be put in the room, roomed by the medical assistant at, the top of the hour at the appointment time. They would spend the first 10 minutes rooming the patient, starting the note, doing all this, getting the vitals. And then I would come on 10 minutes, after the start of the visit and do my visit. But for video visits, somehow it's expected that at that appointment time, that's when my face shows up and I'm doing the visit. So it's hard to have in-person visits starting late and then be on time for your video visits. So we're encouraging patients to be coming early for their in-person visits, by 10 minutes, so that we can get them roomed early, get the rooming process done and completed for the time slot of my visit.
Thanks, Dr. Garber. Dr. Mishra, anything else to add on the physician experience front?
No, I think Dr. Bhatt and Dr. Garber covered a lot of ground there. I'm responsible for about 1,200 providers here in terms of training. So I think training and really leading in terms of what it really means for the patient, what it really means for them moving the future really makes a huge difference. And I think that was very well stated. And listening to we did in the middle of pandemic, two surveys to listen to the providers. We did change, actually added 2 more platforms to support the providers, because it's not always that they don't want to do it. It is more about, as an informaticist, you need to make sure that this whole workflow structure, the whole support structure, the incentives, how does it really improve that experience for the patient and really creates the outcome? And we talk a lot about data. You know what, Dr. Shah, you are a cardiologist and CHF expert. We have seen that you're able to still keep 80% of your volume, and the patients are so thankful, and they're not coming to the ED. So I think data also speaks a lot.
Can I jump in on that for 1 second? You said, as an informaticist, and I realize we didn't talk about this, as a clinician,
Yes.
One thing I've learned now is if my IT counterparts are not involved from the beginning with what I am thinking clinically, things do not go well. So I think you need to recognize your team is maybe, we talk a lot about team-based care with our nurses and nurse practitioners and PAs and us, but really for me now, it is the people who are in IT with me, the administrators who are doing some of the crosswalking and billing codes, which we'll get to in the next section. And then the people who help the administrative assistants, who are the ones on the phone, helping them understand as well, because there are a lot of times, and this is going to John and Judith's question in the chat, what do you say to a patient when they say, when is your office getting back to normal? Part of the reason they were saying that is our admins were saying, yeah, well, it's COVID, so you're not going to be able to see her in person, and therefore we're going to do a virtual visit, and we've set it up, so of course they're going to ask that question. So I think my answer to that chat also is our team's a little different now, and that first voice they hear has to be a reassuring voice. Wow, it's so exciting. Dr. Bott's doing virtuals on Wednesday. She can see you first thing in the morning. What time do you drop your granddaughter off again? Oh, we can get you in before that. And I think it's a little bit of messaging that has to be done at every level. If even one level in the office does not message what you message, people will really hold on to that.
Yeah, thanks for touching on that audience question as well. And I think we have a hand up I want to get to before our time is up. It's an email address, Saint5510. You've had your hand up for a little bit. Did you have a question you wanted to ask? Maybe not, that's fine. So I have one question to wrap up for you all. How do we do this equitably? How do we do telehealth? How do we do remote patient monitoring in an equitable way in our care? Any recommendations?
I'll jump in. I mean, one of the things we've seen is there's the technology inequity, and so we're starting a pilot where we're basically delivering technology to the home just in time, just for the visits. So we've got iPads with cellular cards. We had originally piloted this with single carrier, and we found that that didn't work at everybody's house. So we're literally driving to the house with 3 different SIM cards and finding out which carrier is best and swapping that one in and having the patient use that for the visit, and then picking it up the next day. So we're just starting this pilot. I'll let you know how it goes, but that's one way at least to help with some of the disparities.
Yep, the tech access is a huge piece. Dr. Mishra, anything to add?
Kate, you're touching on a really, it's an issue which we really need to touch on as a digital divide still continues to grow. There's a lot of funding which we also need to kind of continue to understand. So like, for example, FCC has this Lifeline program which supports patients with this low income and having need for some kind of a communication device can be paid up to free. There's also lots of programs from HRSA, from a lot of different companies and Microsoft to kind of also taking the leverage advantage to put that technology at patients' home and provide. But this digital divide, I think we all need to come together and talk to our legislatures, because I think this is going to be a barrier if we don't. It should be like electricity, it should be like gas, it has to be in each and every patient. And this is a long and very windy road ahead, but I really appreciate you asking this question, and there's no other way rather than coming together and talking about this. And we take care of a lot of Medicaid, Medicare patients. We see inequity in the town, in the vicinity where the hospital is, downtown is, and how do we kind of bridge that? So a lot of health systems are also investing as well. Like for us, we are right now providing remote patient monitoring for free. We're just eating the cost because we don't want the patients to come back again in the ED as well. So lots of different thought processes, but really important topic. Thank you, Kate.
Yeah, and you're definitely right. It's not just an individual physician or practice or healthcare system solution. It's at the advocacy level as well. So I know we're hitting past time, but Dr. Bott, any final words?
Yeah, I will. So this is what I study, the disparities in access to care and telemedicine. And I will tell you, it's an enormous problem. I think the idea of pilots are key. I think a lot of companies out there are more than willing to help you and your institution do the pilot to prove the work. In order to be able to increase, quality and safety. So we have Amazon tablets going out into the community. We have blood pressure cuffs that we're actually giving out in the community. And those are not on our cost. Actually, those are the companies who are coming forward to do it. That's not a long-term solution. They're not going to necessarily be able to do it forever. They're businesses as well, but I think they can do it long enough for us to make the argument that it's necessary. And I think that's what we need is quality studies. In terms of advocacy, I don't think that we can vie for broadband alone. And so I would encourage, everybody here in the AMA to work together with our educators, because getting broadband into communities to improve education, now that education is virtual, this is probably the last year we really have the chance to band together with them and say both education and healthcare are right. And therefore we need to be able to make policy changes, not sequential waivers that will end next April, but policy changes. And so I do think that that's the direction that we need to go in. And then the last thing that comes from the chat, interpreter services could not be more important than at a time like this. And so again, back to workflows, knowing who you're using, and if your institution, your practice doesn't have enough bandwidth, there are a lot of companies out there for interpreter services that can be done by telephone, that can be called in by video in a HIPAA secure manner, but really having that up and ready. And again, having administrators, medical assistants, nurses, all be aware that these services are easily provided with Kittle keys and, cards up on their desks at home as to how you're going to get that set up. And then encouraging our patients to not say it's okay anymore. It's okay, my daughter will translate. And I think we have to say, actually, we prefer that we have an interpreter for you. And it was important before, it's even more important now because so much can be lost without body language in those situations that I think it's really important. Thank you, by the way, if I can do one last word. What a phenomenal morning so far. It's going to get even better next and maybe a little bit exciting when we get to the billing and these codes, but just the conversation in the chat and knowing that so many people are out there, making sure this doesn't just disappear in the next 5 months.
Yes, I could continue this discussion for a really long time, but I know that Bernadette and Stacy will not let me. So thank you to all of our panelists. Really, really appreciate your contributions this morning. It's been a pleasure to be able to moderate, and I'll hand it back to you, Stacy and Bernadette.
Fantastic. And we can continue to take questions in the chat for those of you that have any. This next panel focuses on exploring the variety of quality and payment models for telehealth. And joining us today to moderate is Dr. Russell Libby. Dr. Libby is the founder and president of the Virginia Pediatric Group, a primary care pediatric practice in Northern Virginia. He has served in a variety of leadership positions at the American Academy of Pediatrics, Medical Society of Virginia, and at the AMA, where he serves as a delegate representing the Integrated Physician Practice Section. Dr. Libby is also a board member at the Physicians Foundation, where he has led a variety of efforts in guiding investments in physician wellness and telemedicine. He's also the chair of the Telehealth Initiative program. And with that, Dr. Libby, I'll turn it over to you to introduce the rest of the panel.
Great, thank you, Bernadette. Boy, it's been really incredible to listen to the discussion, to hear the expertise, and to see the sophistication that has really occurred over the last 6 months. It is amazing to me how quickly we converted initially just to be able to accommodate the care of our patients during the early COVID days, but to see this impact in terms of thinking outside of the box, to moving forward, to thinking about how we are going to be able to evolve what we do and how we provide care to our patients. You know, obviously, telemedicine's been a big part of the COVID evolution here. We've really embraced it. Our patients seem to have embraced it. Even payers and the regulators seem to have wanted to come and support it. So we've been able to really take it to a new level. But I think once the dust settles and we see that really there isn't that much more money that the Treasury can print, and that our healthcare systems are really hurting, we're going to find that we're going to have to innovate, and certainly finding ways to provide care without the facility-based expenses that we deal with are going to be really super important. And it's going to be us who has to do this. We all live in a fee-for-service world for the most part, and a lot of us don't really know how to anticipate how we develop value. Certainly there are lots of plans out there, lots of ways that the government and payers have tried to create value-based contracts and to define what that might be and how you pay for it. But for the most part, it's been hard to do. I think telemedicine and the technology we've been talking about today can really enhance that and be an important part of that paradigm. Certainly, I think we can say that we've moved into the 21st century, because as you know, we've seen some of the comments, we've heard some of the speakers, docs sort of want to gravitate back to what they know they can do best and generates the revenues they're used to. So I think remote patient monitoring has to be a big part of this. I'm curious to see how that's going to happen, how that's going to evolve. And I think that there are a number of organizations that are poised and ready. And we have several panelists with us today. We have Dr. Tom Cornwell, who is a great physician I've known for many years. He is a senior medical director at Village Medical at Home. He will introduce himself and to talk about some of the things that they're doing. Dr. Keith Fernandez is the chief clinical officer at Privia, which is a large integrated physician practice organization, which he will describe and talk a little bit about what they've been doing. And our third panelist, Carol Vargo, is from the AMA and directs their work on practice sustainability. So I would love to start just by hearing, because going back to where it's all started and how that's going to inspire you based upon the experience you've had over the last 6 months in your organizations. Dr. Cornwell, tell us a little bit about Village MD, what you've been doing there, and what impact COVID has had on your operations and how you've adapted a little bit.
Well, this has been a year of change for all of us. And but for me, I would have celebrated 30 years at my health system in July, but went to Village MD. And so I was part of a Central DuPage hospital, part of Northwestern Medicine now in the Chicago area. And in March, I joined Village MD. Obviously, none of us knew COVID was coming. The last 25 years, I've made over 33,000 house calls. And so I devoted my life to home-based primary care. And I joined Village Medical, that is essentially a value-based primary care organization that's in 8 states, 9 markets, to spread home-based primary care throughout their markets, not knowing. And so I started in March. And what was interesting is I really had a tale of two worlds with telehealth. Because when I started, I still contractually was doing clinical care for Northwestern between March and May. And so, you know, what I learned was, just like we heard from the other panel, you know, I would say that Village is really a rapid cycle, you know, improvement organization. You know, they're just so used to change that when something happens, I could see how they could just pivot so quickly, unlike what I was kind of used to, a part of a more complicated healthcare system. And so within 2 weeks, they went from one administrator. They had already been looking into telehealth, like we heard from the other organizations, but within 2 weeks, literally 93%, 151 of their employed doctors were on telehealth by the end of March because they have both employed as well as what they call affiliated physicians that are more like on a management service organization model. They had 512 doctors on the system and went from 0% telehealth to within 2 weeks, 80% of their patients being on telehealth. Now that number, we heard that, we've gone more to a blended model. We're back to about 40% of our total visits. And actually during March and April, also there was only a 15% drop in visits, because of this rapid cycle improvement and really pivoting and getting on telehealth. And I'll just say, and there's great things about complicated health systems, but literally even in May, the health system I was a part of was still talking about, what system are we going to use, and was really not, I would say, up to speed in terms of what I noticed. And actually my house call program was the first practice on telehealth because I brought, Village actually used a platform called DoxyMe that, and it actually has a free, this is important for you to know, it actually has a free part of it. It doesn't have necessarily all the bells and whistles, but I've used both and both work well. But we used DoxyMe, and I actually brought that to my house call practice. So we started telehealth in March ahead of the rest of the system. And the one thing I'll say about my telehealth experience is it was actually, to me, kind of shocking and scary how effective it was. We are dealing with the patients that I see are, the sickest in our community. We actually have about a 25% annual mortality, and about 76% of those patients pass away at home. And so end-of-life care is a large part of what we do. And so it's a very relational type practice, working with caregivers. And I just found telehealth to be remarkable in terms of providing care. I only made 2 face-to-face visits between March and April, and that was one was for a trach change in a 40-some-year-old, and also in the 40-some-year-old a G-tube change, which I obviously had to do, face-to-face. But so I found it, quite remarkable, quite effective, and I've been interested to see how. So often when I've heard other doctors talking about telehealth, they comment how wonderful it is to actually be able to see the patient's environment, something that I've done for 25 years. And about this, Russell, because, you've done house calls. But it really, there is things about telehealth that really brings a greater awareness of the patient. And I said the last thing, but one more thing is, and I heard this on the other, is that also to bring in caregivers has been quite remarkable, where literally if they're in other states on the platform, you can bring in other caregivers so that they can actually be a part of the visit. And one of my patients in an assisted living facility, I brought the nurse in to serve as the phone for the visit, and then brought the daughter in because the patient had Alzheimer's. But literally, it was the first time in the month that the patient was able to see the daughter. And I actually let them talk for the first 5 to 10 minutes. It was just so warming to see the joy of this patient who hadn't actually seen her daughter for a month and was able to communicate. And so I think I'll stop there and hear what Dr. Fernandez.
Thanks, Tom. And it is really amazing when you think about the fact that somewhere like 4% of the population generates 60% of the medical cost. And if this population is so expensive and you can cut 20% off of that cost, that's a huge savings for the healthcare system. And it should go back into doing things like we are planning or hoping to accomplish through this technology and telehealth. Keith Fernandez, tell us a bit about Privia and about the experience you guys had in the transition into COVID.
Hey there. Privia is a kind of multi-state medical group and services provider. We are in actually Florida and 2 markets in Texas right now, in Fort Worth, Dallas, and Houston, and in Florida, in Central Florida, Melbourne area. Over the country, 2,500 providers. We've been very interested in virtual care for a couple of years, have an embedded virtual care platform in the EMR. So our philosophy and almost everything is to have one platform so the physician doesn't have to hop in and out to do these kinds of things. And all the information that comes from a virtual visit, the billing that goes out from a virtual visit is all done on a single platform. And very much interested in value-based care. Our purpose is really to take physicians wherever they are on the spectrum of doing value-based care and bringing them along eventually to taking risk. I think risk is one of those things that will be like COVID a little bit, so that once we get to risk, the need to change and to do different business will be an imperative. I think the biggest thing there is access. I'll say a few words about that. So we have this great virtual platform. We have a large number of doctors who've signed up for it. They do have to pay a very small fee to do that. We didn't want people on the platform who didn't have some stake in the game. We had 144 visits per week prior to COVID. Within 2 weeks, much like Village, we had 8,000 visits a day across the country. We, of course, had to reorganize our teams, our educational stuff, training in how to do virtual visits, all of the stuff that people have talked about with, how do you get a physical exam on a virtual visit? How do you convince people to do virtual visits who go, I'm just going to wait, I'll come in when I can come in. Some of the interesting things that I think really changed is we actually did training on how to change your office so that your medical assistants and other support staff who are no longer, having to do the in-office patients really do it very effectively virtually and really prepare that virtual visit before the doctor has to get involved. The other thing that I think was important is our revenue cycle teams continuously kind of monitoring who was getting paid, who wasn't being paid, and what was going wrong in the payments for virtual visits, because as you all know, the payers were rapidly trying to, figure out what they were going to approve or not. We had built into all of our contracts in at least our largest market in Northern Virginia, Maryland, and DC. We had in our contracts with all the payers parity virtual visits already, a little bit easier. And it was really, really helpful to have the revenue cycle team monitoring who's paying for what and all that, so that we could help the physicians actually get paid. It depended we have a lot of specialists. We mostly are primary care, OBGYN, but we do have a significant number of specialists. The specialists really dropped off and had a hard time, generally speaking, adopting the virtual platform. Medical specialties did a lot better. Surgical specialties a lot more poorly. But our endocrinologists actually were the very best at getting quickly onto a virtual platform. I think the same curve that Tom mentioned, a very high adoption and utilization at the beginning of COVID, and then it has tapered down, and it depends on the specialty. It's as high as 40% still in some specialties. Our total average is around 20%. And then I think I'll stop there, but I think, there's a lot of stuff that goes with that and how you move into this future, stuff that you've already talked about. Remote physical exam is, I think, in the same category as a remote patient monitoring. I think that's more and more important. Remote testing, I don't know really how to describe that, but testing delivered to the home, a whole lot of companies in that space right now, delivering blood tests. Someone mentioned earlier the strep tests. Remember, I'm going to point out strep tests for a reason, because almost all of our value-based contracts have moved pharyngitis into the value-based metrics. They added adults. That was in children before. Now they've added adults to that. And I think there is a sensitivity amongst doctors doing these remote visits. There's more fear. Geez, am I going to miss something? Shouldn't I just go ahead and give antibiotics? And so I think rapidly developing those kinds of tests and ways of dealing with that are really critically important, and also because it's the right thing to do. I'll stop there. And
great. Thank you, Keith. And you guys have your feet on the ground, and that is the reality of healthcare and healthcare delivery. Carol, you obviously work at the AMA, and they've been focused for a long time on telehealth. But in the course of the COVID experience, what kinds of resources have they developed, and how they've been looking at this as to how they can help support physicians? Obviously, this is one of the initiatives, but in terms of what is accessible.
Great question, and thank you for having me, and good morning or afternoon to all our panelists and participants. This has been an excellent program, so I'm thrilled to be here and working with the TTI partners on this. So as Dr. Libby pointed out, immediately when COVID hit, we were really well prepared across the AMA. And just as a level set, I work in our professional satisfaction and practice sustainability group, which is really focused on helping those physicians in practice, regardless of their setting, regardless of their payment model. You know, we have reminding many physicians continue to be solely in fee-for-service. Most likely the majority of them now are in some sort of blend, full on to where Dr. Fernandez was talking about in full capitation. So that really makes our jobs challenging and trying to meet the needs of all those clinicians, but we do it and we do it well, I believe. Certainly my colleagues in the telehealth work that we do, we're very well poised to help physicians adopt telehealth. For us, it became really much more of a financial pressure, as we know so many physician practices who were providing non-essential care really struggling to keep the doors open. Many of them had to close because of executive orders across the country. So we immediately developed a significant and available and free to all physicians, regardless of membership at the AMA, series of tools and resources around financial sustainability, financial planning, keeping them abreast of all the various changes going through with regard to CMS. Of course, working very closely with our advocacy colleagues on getting a lot of the programs that, whether it be the advanced payment program for Medicare or some of the PPP loans available to physicians, and really updating that information in a real-time basis. So I would say initially we were very much in the sprint of COVID, but we all recognize at the AMA and as well as you all that this is now a marathon. So we've gone from focusing on helping physicians keep their practices, or we've gone from helping physicians reopen their practices to now really focusing on how do you keep your practice open? And clearly telehealth is one of those very important aspects. So we have a website and all our resources are available there. So with regard to contracting and payment, as I've noted, we're now in the marathon portion, and what we've really begun to do around telehealth and a variety of issues, engage with the commercial payers and in particular around what is sustainable going forward. I think it's been noted by every panelist this morning, starting with Dr. Kvader, the infrastructure for a physician office to put telehealth and remote patient monitoring into place is significant. How do we ensure that those payments going forward ensure sustainability for the adoption of telehealth going forward? So I'll stop there and hopefully have a really much more robust conversation with my fellow panelists.
Well, I do want to ask you a little bit more, because obviously one of the issues, the topic of discussion here is value-based contracting and using telemedicine and remote patient monitoring. How do you view what's going on now in terms of what it's going to do to the value-based contracting efforts with all the background that we've heard? Just give us a perspective from the 10,000-foot view that you have, sort of surveying what's going on.
Sure. And I think this perspective is one from a lot of engagement that the AMA is doing now with not only the health plans, but also the large national employers who are ERISA-funded plans, who are really driving a lot of this move to value, as you know, Dr. Libby. I think we've always been focused within the AMA on pursuing and educating clinicians and physicians around how to engage in value-based contracting. Clearly, we've been saying that it is the wave of the future. Clearly, the movement's there. The signal has been coming much, even far before COVID, both from the Medicare and the Medicaid, all those public payers, as well as the commercial payers, of wanting to get more and more people into value-based care contracts. I think it's been market by market in terms of how readily that is adopted. I think during COVID and the immediate crisis, a lot of that discussion was going away. People were just focused on the immediate need. I think with regards to telehealth, we saw all the waivers that are now encouraging reimbursement. Many commercial payers went to parity with what CMS was calling for Medicare, and that was all positive. I think now people are pulling back and trying to look at where the evidence lies, what the best practices are with regard to reimbursement. I think there is absolutely a keen interest on advancing telehealth in the context of value-based care and value-based contracting. I think that will continue to increase. For those of you who are already in capitation, like Dr. Hernandez, I think you've already been able to show the value there. I think the challenge will be to get other clinicians who want to adopt these strategies to be able to make that case that this can improve outcomes. But we also have to ensure that these practices that we are being reimbursed adequately to support the infrastructure for the provision of that care.
Yeah, I think those are huge and very important points, and it's really good to have the advocacy of the AMA, our national organizations, as well as our state organizations, to make sure that at the legislatures, in any of those regulatory settings with the payers, et cetera, that we have the right kind of positioning so that moving forward, we don't get cut off and have our investments not pay off. Once again, this is 21st century. And I think that even a lot of our, let's say, background is easy to gravitate back to what was, what worked. But really, thank you for that kind of effort and being having your eyes open. So we know we've identified a few chronic diseases and conditions. Dr. Fernandez, tell me and us what you think are some of those conditions you think might give you the greatest return on investment. I mean, you've got a majority of your practitioners are primary care, you've got some subspecialties, and where do you think that will give you the best bang for the buck and give patients the best outcomes?
Well, I'm happy to talk about that. I want to go back just to one thing I said, though I thought it's an important concept, and that is, as we shift to virtual care, you know, we have metrics for almost everything. We probably ought to be looking at how we do with virtual care. The example I used, are we delivering way more antibiotics? You know, are we actually increasing utilization in some fashion of certain types of medications? So I think it's going to be important, especially with the payers who are really looking at this right now going, oh no, you know, we're going to have everybody doing a virtual visit every 3 minutes and it's going to cost us $1 gazillion. So I think pretty soon we probably ought to lead out on what a good virtual visit, you know, about how many to do and things like that. So I think of again, with risk in particular, taking really high touch concierge type care of patients. They should have access anytime, anyhow, wherever they need it. And I think whether when you're in a risk contract, you don't have to worry about the per click, right? You only have to worry about the patient outcome. How is that patient going to do? And build programs around that. And the virtual stuff just gives you a great opportunity there, along with the remote monitoring. We've had ongoing programs that use a combination of virtual care for the usual diseases, I think. Obviously, heart failure, COPD, diabetes. Diabetes usually is a multiplier on any other chronic condition, so you can't just manage the heart failure, you've got to manage the other kinds of problems synchronously. And then you've got to think about virtual health. I think when we looked at our populations and also everything ever written, if you have a behavioral health issue and a chronic condition, you're not going to be successful with those patients. You're not going to be able to save money unless you address the behavioral health issue. So before COVID, I think COVID has accelerated everything. We were working with those high-risk populations. We discriminate a little bit about heart failure, COPD, and diabetes, but really it's anybody with an advanced illness that we want to manage differently. And a lot of that management doesn't have to be fancy. It's just kind of high touch. How are you doing? Do you feel sick? What are your vital signs doing? Are you taking your medicine? It's not, really complicated. And now I think it's going to be a little bit cheaper. So when we have these patients, we already had a behavioral health partner in my doula that we can engage on these chronically ill patients as we take care of them. We're using remote monitoring for the usual fairly typical stuff, blood pressure, O2 sats, blood sugar, those kinds of things, and have already demonstrated, this is actually before COVID, some very dramatic reductions in admissions, readmissions, and ED visits. We go places where it counts. So I want to prove these models, so I don't go to River Oaks in Houston, one of the richest communities in Houston, but I want to go to places where social determinants are, deeply held, places where there are a lot of people that you can benefit. And then I will just tell you this, virtual technology, virtual platforms are all great, but they don't do a darn thing unless you have a highly engaged practice. I used to say highly engaged physicians, now I say highly engaged practices. You've got to have everybody in that practice tuned into what's going on. Sometimes the medical assistant is the most important. So for me, this, the getting to risk allows me to do business with the goal only being, how am I going to do the best by this patient, the best outcome, and I don't have to worry about the technicalities of who gets a virtual visit.
Very wise and very insightful. Good points to make. Tom, I know that Village MD has been more or less poised and ready for this kind of thing. Obviously those conditions, and they fit right into the massive conditions that you deal with on the home-based primary care with the medically fragile group that you deal with. And I'm sure that in your organization, that senior component is expanding to those with the chronic kinds of diseases that don't have to be seniors, but can be very high cost, revolving door hospital type patients. But tell me a little bit how you see this for your organization and what kind of technology you think is easy to implement to be able to monitor some of these things, because there are lots of levels, that's for sure.
No, and a couple things from what has come up. Again, this has been as I'll just echo, this has just been a wonderful few hours. And one of the questions that Dr. Sullivan put in is, what are the articles out there? I know before value-based medicine, the articles that came out on telemedicine RPM were actually, in terms of cost reduction, were not good. Oftentimes they showed increased cost reduction, but I think, or increased cost. And I think the reason was because before value-based care, when a busy provider was called with an elevated weight or shortness of breath or something, what did they do? They said, call 911. And so, I have not seen, more recent articles, but I think Dr. Sullivan's question, and this gets into Dr. Fernandez's talk about metrics, it's just a wonderful time to actually not just show its value in terms of studies, but, how to best do this. The other thing I just want to say based on Carol's comments is I do want to put in a plug for the work that the AMA has done. 45% in that initial poll of people on this call are not doing RPM. And the AMA has really put together what I think is an amazing book, 6 Essential Steps to Building a Scalable and Profitable Telehealth and Remote Patient Monitoring Program. And, when you open it and it's 100 pages, you kind of think, oh, do I have time for this? But it really is a user-friendly document. There's a lot of graphics in it. It's not all text, but the last 40 pages are resources. There's 12 steps that they go through in terms of how to get this up and running. And the last 40 pages are resources. And so when they talk about evaluating a vendor or vendors in terms of, they actually have in the resources, here's the questions you need to send your vendors that you need to know about them. And so it really is, I think, a very effective way that I just wanted to make sure people, heard that during this time in terms of as they're considering going in this direction. And then to answer your question, and so like Dr. Fernandez, you kind of, especially in risk-based, one of the things is you do a lot based on data in terms of risk stratification. to find both your high utilizers as well as your potential patients for high cost. And typically they are the things that Dr. Fernandez said, the heart failure and COPD and diabetes. One of the things that he got to also is part of our remote patient monitoring. So we are first going after, this started recently, going after heart failure and COPD. But there's also, not just the biometrics, there's also the questions. Just every day patients are asked set questions that, to find out how they're doing, not just get a bunch of vital signs, I think is critical. But I really loved, one of my take homes from this is what we heard about the one-to-many, because another nice thing, and we also heard this in the last panel about physician burnout, is the one-to-many. We have standing orders for nurses based on increased weights and doubling diuretics, based on COPD exacerbations and what to do with the rescue pack, how often to do phone follow-ups on these patients with the RNs. When do you bring in the patient within a 24-hour time frame for the doctor visit, because they're now in the yellow zone or red zone with these protocols. But I really think this is a way to really utilize in value-based payments people to their highest scope of training, and really unburden providers, not burden them more with a lot of data, but literally unburden them by having providers in place that can really take care of the less severe cases through remote patient monitoring.
You bring up some incredible points along the way, and it makes me think, as you do remote patient monitoring, and I know there are lots of issues about what that is, how you capture it, what you do with it. But I know that in the NICU, in the neonatal intensive care unit, and in oncology, there is a continuous flow of data in that helps dictate best practices. And to me, when you start to be able to categorize patients based upon clinical diagnosis and the data that you're getting in, all of a sudden you're going to have remarkable data that would take years sometimes to collect and then to analyze. And I guess, Carol, you can even answer to this a little bit. The AI approach, as we like to say, not artificial intelligence, but augmented intelligence, is something also that the AMA has been focused on, much probably to the curiosity of those who may be part of this this audience. But tell us a little bit about how you guys see how this might evolve, and what you're investing in, both in terms of your intellectual investment, as well as even possibly some of the hard innovative investments.
The AMA has a really strong initiative around AI. I think blending those two into the talk around what we're doing in terms of telehealth and remote patient monitoring is crucial. I think, if anything, I think all I would like to say, just to impart some high-level wisdom, is any of this that we're doing, I think we have found we cannot do in silos. And I think this gets to some of the questions, for example, from Dr. Bott. We need to be making these decisions with the other key stakeholders at the table, right? So I think there is a tremendous amount of interest around advancing AI, a tremendous amount of interest around advancing telemedicine, but there's many other players involved in this, technology companies, vendors, the payers, the patients, along with the clinicians. And I actually think there's an opportunity at this moment, and this is what we found in many other avenues and areas, that we do come together to try to figure this out together. I think we have some great examples from our DIMPAG around the digital payment advisory group. I think there'll be some other opportunities there. We bring a lot of folks to the table on AI. I think that's really what it's going to take in this very rapidly evolving, highly complex system and technology world that we find ourselves in.
So here, once again, we have two representatives of large organizations of physicians who really do take care of patients. And we want to advance and find ways to really survive into the future, both as practitioners as well as supporters of the values and the inherent altruism of our profession, which is to provide good care, to improve population health, and to actually continue to be able to be physicians because we generate enough revenue to live off of it and to enjoy our lives and the professional side of it. So how do you approach payers? How do you devise? I mean, there are not many of them out there holding, you know, a contract in their hand saying, here, you improvise and tell us what you're going to do and we'll pay you for it. Keith, have you guys been able to really effectively engage payers in this process? And how do you think you could advise some of the participants here in how they might handle that going forward?
It's a tough business. I think we have partnered, you know, we have very good relationships with the payers and have at least come to the ledge of doing things that are very innovative, just changing the way that we practice medicine. Just quickly say that whenever I talk to a payer and they tell me who my bad doctors are, they're always in areas where social determinants are heavy, right? And I think, boy, the bad doctors are all in those neighborhoods. There's only good doctors in the rich neighborhoods and bad doctors in the poor neighborhoods, which of course is completely wrong. So we do have a project ongoing now, and it was pre-COVID, but accelerated again on the practice of the future that basically looks at a virtual combination of a virtual and physical practice. What Dr. Bott said earlier is critically important. Now, we can't launch forward with this whole process without including doctors and how they feel about taking care of patients. I think that's absolutely critical. And to be able to do this, we need to have partnerships. I think many of the payers are getting very reluctant about all this virtual business being persistent into the future. But I think we need to convince them that it's going to be very, very effective way of getting into the future. We do have some things in virtual health that I think are important. One of them is we partnered with several payers during COVID to become their kind of backup virtual provider. They have a relationship with Teladoc and other organizations that were overwhelmed, and we became embedded in workflow in the markets that we're in. So I think there are many ways to partner. We want to partner. The best way to partner is to get into a risk relationship because it's meaningful for both sides then.
Good point. And yeah, it seems that, and also it was pointed out in the chat that getting your employers, those who do still have some role in choosing and helping to direct what kind of care their employees get is probably essential. And of course, even still, when you think about what going to the doctor represented before telemedicine, it has enhanced the way that care can be delivered without having to build a hard space in an office setting or some other accessible area. Tom, you have anything to add to that specifically?
Well, not to disappoint. And so we heard from the last panel that people were going to be hearing about billing, which really hasn't come up. But to Dr. Fernandez's point, one of the things you guys might have heard that Village made this partnership with Walgreens, and actually 50% of the new Walgreens clinics are going to be in HHS underserved areas. And so we're really excited about being in primary care. But the one comment on billing I want to say is that, there's this 99454, which is just having the equipment in the home and having the patient at least 16 days report data. That alone pays $65 a month. And there are organizations out there that have just really, what I would, Swift, I'll just say, really quality materials. They have like they'll give you a phone for the patient that is for communicating. It can serve as an emergency response system. It'll tell you when the patient's fallen. It can be a GPS fence, meaning you set the perimeter, and if the patient, if the Alzheimer's patient leaves the home, it'll notify you that they have left the home. I mean, that's just, one thing, but what these organizations will do is they will charge you like $50 a month for their package deal that comes with a scale that, Bluetooth to the device that sends it to you, that, you know, whatever you kind of want. They have different packages. They have a COVID package or a heart failure package or a COPD package that, you know, might have a pulse ox, but not the scale. But my point is that they will charge you $50 a month for this, you know, quality, you know, material. And then you bill Medicare $65 a month. And so there's little financial risk, but obviously you also have to have, there's cost of employees in terms of implementing this. But then if your staff, your RNs that are reviewing this, or whoever you have reviewing it, talks to the patient based on this material 20 minutes a month, then you get another $51. And then if the provider has to spend a half hour, you know, reviewing it, you know, there's another $60 fee. And so I just did want to add this. And again, I'll go back to the AMA booklet that really goes through this information so that you can make a business case out of this. But I just wanted, you know, to let you know that there are those opportunities where literally the vendor, you know, gives it to you at less of a cost of what Medicare covers per month. And that way it just makes it, I think, an easier business decision, having been someone, as you know, and for 25 years, having to struggle to keep my house call program going. You had to become good at not leaving dollars on the table. And so there are these CPT codes that are available.
Yeah. Okay.
Could I add
Yes,
something
please do.
to that just quickly? I think
close.
that is, you know, I think if I could again just sort of underscore sort of a key takeaway from this discussion is that I think there is a lot happening right now, and I think those are all very important. I think the biggest challenge is to make that sustainable over the long term. And I think that is job number one for us. And I think the AMA is doing a great job on, we have an agenda on research to actually come up with a lot of this, hopefully, discussion around ROI, improvement in outcomes that can be shown, you know, what the cost is of infrastructure, so that we can make the best case possible to those large employers, to, you know, who are actually truly the real payers, to the health plans, to the policymakers, that we are doing all the wonderful things that everybody on this program said this morning, which is investing a lot of time, effort, and energy in really figuring out what 21st century telehealth medicine looks like. And I do want to say that, you know, medicine has to do this because there are plenty of other competitors and providers out there that are willing to have, you know, contract with a large employer and carve out the role of the clinician, of the physician. And I think we really need to keep the physician practice front and center in delivering this kind of care, recognizing it is absolutely team-based, but what does that look like going forward in the 21st century with the use of telehealth? I take great comfort in the fact that we are all doing that work. I just think I want to underscore that this is the job going forward for all of us. And it's not going to be data coming in overnight. Absolutely not. But to the extent that when you're talking with your payers, you know, on the ground in your market, and you're showing them the data that you have right now in terms of outcomes, in terms of efficiency, that will get you much further than sort of sitting back and waiting for them to come to you. But the AMA is working tirelessly to try to make sure that we have at the national level, and I'm sure the state medical societies at the table here today are doing the exact same thing, giving you the data to really help you do that.
That's great. I know we're at the end of our time slot, and I see Shannon and Bernadette popping their faces into the picture to remind us of that. And I really appreciate the work and the insights of the panel. And thank you all so very much for being part of this.
Thanks for everyone for spending your Saturday with us. It's been really informative.
Thank you.
Fantastic. So just to wrap up, I know there are a couple of questions in the chat here. We'll be sure to respond after this event. And again, a reminder that we do have an online community for any questions. So want to continue this conversation on the Physician Innovation Network as well. So if you have any questions on accessing that, you can contact your state medical society representative. And with that, I'll turn it over to Shannon to wrap us up.
All right. Thank you so much, Bernadette. We did have one more poll about if you think that you will continue with remote patient monitoring. Unfortunately, we are out of time, so we're going to bypass that. Just one more quick reminder that we do have this approved for 2.5 hours of CME. I noticed many of you putting your name and email in the chat. If you did not do that, please do so. And I'll keep the meeting open just a few minutes after we end so that you'll have time to do that if you haven't already. Just a great big thank you to our presenters, our panelists, but most of all the participants. We are delighted to share this information with you, and we hope that it has been time well spent, and may you have a great rest of your Saturday. Take care, everybody.
Thanks all.